So much for watching, and we hope you join us and ask us questions in our live discussion with Dr. Camelia Lawrence. She's a breast surgeon at the Hartford Healthcare Cancer Institute. I'm so happy to have you here today.
Thank you for having me, Tina. I'm delighted to be here.
Absolutely. So you are part of a comprehensive team, a multidisciplinary team at the Hartford Healthcare Cancer Institute. Tell us about this team and what it takes to really offer this coordinated care.
Well, the management of the breast cancer patient is multifaceted, and at Hartford Healthcare we have a team of experts, which includes our medical oncologists, radiologists, radiation oncologists, our pathologists, a navigator, and we all come together to determine for each individual woman the right treatment algorithm. So all cases are presented at our tumor board, where we all hash out the details of the clinical presentation and that patient's tumor biology in particular, and determine what is the best treatment approach for that woman.
That sort of dictates the course of action that you take from there. And it's so important to have all of those components coming together because they offer so many different elements, so many different pieces to the whole treatment plan.
Oh, absolutely. Surgery is only a part of the algorithm. So, you know, we all need the additional expertise from the other providers in order to provide optimal treatment for these patients.
One of the unique things about the Hartford Healthcare Cancer Institute is our partnership. We were the sort of founding member of this alliance created with Memorial Sloan Kettering Cancer Institute. Tell us about that, because this is critical to patients that living in this area. It gives them that access to care that they wouldn't otherwise been able to get here locally.
Yeah, absolutely. It was an ingenious idea. What it does is bring the latest state-of-the-art clinical trials and treatment algorithm that's available at Memorial Sloan Kettering right here to Hartford Healthcare. So our patients don't have to travel great distance to get that same level of care. It's a unique partnership that allows us to bring some of those clinical trials here locally and have patients participate as well. So as a whole, the patients overall benefit. And for us as providers, it helps us to keep up with the latest technology as well as the treatment options that are available.
Right. And it's not just, you know, for breast cancer. I mean, it's all types of cancer. There's, you know, hundreds and hundreds of clinical trials that, being a part of the Cancer Institute, any type of cancer you have access to.
Yeah, just about every cancer, breast, lung, prostate, just to name a few.
Yep. So let's talk about precision medicine when it comes to cancer. We hear a lot about this. You hear it's sort of that buzzword, but what does it really mean for folks out there watching?
Well, I think precision medicine really drills down to identifying the treatment that's going to be best for your particular cancer. We know that the one-size-fits-all algorithm is no longer acceptable. So what we're doing is learning more about that particular tumor. I'll tell you, for example, in the breast cancer world, we look at the tumor biology, looking at the receptor status, we're looking at immunotherapy, targeted therapy, and really drilling down to identify a treatment option that's going to be best suited for that patient. And the overriding, the overarching goal is really to optimize the survival for that patient who's affected by the cancer.
And I think it's so important too with precision medicine, and we see a lot of immunotherapy, is that we're so precise now in our treatments, and we can be specifically targeting areas that only need to be targeted, that are not affecting any other areas that don't necessarily need to be targeted, right?
Absolutely, and what that does, it minimizes the adverse effects as well as the side effects. It's just more targeted therapy. So it's the way of the future. We're excited in the clinical world regarding this, and the more we know, the better enabled we are to treat our patients.
Yeah, and that's something that didn't happen as of a few years ago. No. You weren't seeing that.
No, we are constantly gaining new grounds in research and treatment for the management of breast cancer.
We are talking with Dr. Camelia Lawrence. In case you're just joining us, she is a breast surgeon at the Hartford Healthcare Cancer Institute. We encourage you to ask her questions while we have her in studio with us today. Anything you want to know about breast cancer. And of course, with breast cancer comes the importance of having your mammography every single year, and don't skip it, because really in this case, as in most cancers, early detection is so critical because it's not a death sentence, as you were saying before, having breast cancer.
Oh, absolutely. The diagnosis of breast cancer is not a death sentence. Women who diagnosed with early stage breast cancer are going on to live very full lives. But it's very important that you get your screening mammogram. Breast cancer, some of the types of breast cancer only presents on imaging study. For example, I often have discussions with my patients who come in and say, I don't feel a lump in my breast, I checked myself, I don't think I have breast cancer. Well, one of the ways in which breast cancer manifests itself is microcalcifications, and those are not going to be felt on clinical or self-breast exam, but they're appreciated very easily on mammography. Hence the importance of getting your screening mammogram.
And then taking that one step further, if you're a woman who has dense breasts, you know, a mammogram is not usually just enough. You need that ultrasound to accompany that, so you can get even a deeper dive into the breast and through that dense tissue.
Absolutely. So with the dense breast, it limits the sensitivity or the amount of information that you can glean from mammography. And the reason behind that is that breast density shows up as white on mammography. And breast cancer also shows up as white. So it's very easy if you do have a breast cancer in the setting of a dense breast, so the cancer can blend in with the normal dense breast tissue. Ultrasound is utilized as an adjunct to mammography. It's a different modality of analyzing the breast tissue, looking for any masses or any suspicious findings that may be indicative of breast cancer and may potentially warrant a biopsy.
When does the MRI come into play here? We've talked about the mammograms, the ultrasounds, how they complement each other. When would a woman qualify or need an MRI?
According to the current guidelines, breast MRI is indicated for a woman with greater than 20% risk for breast cancer. So it's an important discussion to have with your doctor to assess your personal risk of breast cancer. If that number is greater than 20%, then a recommendation is that MRI be considered in addition to mammography and ultrasound, not to replace it, but in addition as a screening modality.
Right, and it's nice that we have so many screening options nowadays because, you know, years ago, it's just the mammogram.
Correct, yes. I mean, we use each study to complement each other in order, and you know, that's really the role of the radiologist, and they do a very meticulous job with that through Hartford Healthcare, really comparative assessment of the study. For example, I have patients who have one mammogram, they'll skip for about 5 years and then they won't get another one, and I attempt to impress upon them the importance of getting your yearly mammogram, because the way mammography is interpreted is by comparison. We're comparing previous years to assess for any changes.
Yeah, exactly. And that brings me to the question about having a baseline mammogram. Women prior to turning 40, is it important for them to have a baseline mammogram to say that when they start having their regular mammograms at age 40, you have that initial baseline to compare that to?
It's not currently a standard recommendation to get a baseline mammogram. I think there's some providers who consider getting one at about age 35, but definitely initiating your screening mammography at 40 is paramount.
Yep, and you're going to be having yours in just a few weeks, right?
I will be. I celebrated my 40th birthday over the summer, and I am scheduled to have my first mammography during Breast Cancer Awareness Month, October.
And that's perfect, and happy belated birthday to
Thank
you.
you.
So 40, so if you're out there watching, you know, even the doctors themselves, as you practice what you preach, so you're going to be having yours pretty soon for Breast Cancer Awareness Month, certainly fitting. We have a question from Laura. She's asking, what are the advances from the last 10 years? How has it affected life expectancy? That's a great question, Laura.
Well, Laura, there's several advances that we've had. We now, in terms of research, many of you probably have heard about the TAILOR-X trial. Just to bring an example to mind, is that what has really helped us to determine is those who will benefit from chemotherapy. We've long known, so the TAILOR-X trial looked at how a tumor would behave in the presence of chemotherapy, in simple terms. And we've known, it gives you a score. We've known that patients with scores less than 10 did not necessarily benefit from chemotherapy. And we're talking about a woman with small hormone-positive breast cancer, node negative. But there was always this middle group, this subset between 11 and 25, which we weren't exactly sure, Laura, whether they would benefit from chemotherapy. But if they were a younger woman, medical oncologists tend to lean or err towards the side of giving chemotherapy. With research through the TAILOR-X trial, we now find out that greater than 70% of these women did not benefit from chemotherapy. So minimize the side effects that you would have, such as the hair loss, the neutropenia that comes along with chemotherapy. So we're gravitated, as Tina mentioned earlier, precision medicine, more targeted therapy for your particular cancer.
Great, thanks for that question, Laura. I want to go back to, we were talking about mammograms and the guidelines. You know, there's always discrepancies out there and always some controversy surrounding guidelines. You know, when do I get my mammogram? What, you know, what do you say to women out there?
I follow the American Society of Breast Surgeon guidelines, which stipulates get your mammogram at age 40. There's other groups, consensus groups, such as the U.S. Preventative Task Force, who recommend starting at age 50. But I think most of the governing body adhere to starting at 40 for your mammography.
At 40, and I know we were talking earlier about breast cancer rates among women. We're seeing younger aged women being diagnosed with that. Do you see these guidelines changing in the near future to be lower?
Well, if the trend continues, I think we will. I mean, the average age for breast cancer is age 61, but we are seeing younger women with breast cancer. Last week I had one woman in my practice. She was only 28 years old and did not have a genetic mutation that substantially increased her risk for breast cancer. Speaking of Connecticut in particular, according to the registry data, about 16% of the cancers that we do see are found in women between ages 40 and 49.
Wow. Yeah. And Connecticut is I think it's number 2, or we rank pretty high.
Yeah, we have
the
second highest incidence of breast cancer nationwide.
Yeah. Do we know why? Is it environmental? Is it
The long and short answer is that no, we don't exactly know why. We suspect that there are multiple contributing factors, perhaps environmental, diet. Some think that it may be due to the fact that women are having kids later in life, so longer exposure to estrogen. So we don't really know, but we do know that we have a higher incidence.
We do. And another good kind of tool that we also have is, I want to talk about genetic counseling and genetic testing. It's not just genetic testing. The counseling aspect of it is so important for women with a family history of breast cancer. Talk to us about that genetic component, because I think this is so critical for somebody who does have a family history to go through genetic counseling and thus testing.
Yeah, absolutely. So the majority of breast cancer that we see, we describe them as sporadic breast cancer. We don't know exactly what caused them. About 10% of breast cancer are due to hereditary factors. I think about 5% is due to the BRCA1 or 2 mutation. You probably heard those thrown around a fair bit. But what it does is that it increases, once you have that mutation, increases your risk for that particular malignancy, not just breast, but there are other cancers that are linked to genetic mutations. The important thing is that the testing that we now offer today is what we call a panel testing. So we're checking for a wide variety of genes. And the counseling part of it is crucial, because what does that information mean for you after you get the results, and what do you do with it?
Yeah.
You do need somebody who's able to provide you with the guidance, and patients need to be prepared for what the information means for them, what implications or ramifications will have for their life. So that the testing, the counseling piece of it is just as equally important as the actual testing itself.
Yeah, absolutely. And again, I think that circles back to that coordinated care, that you've got this sort of the counselor driving that to the experts like yourself.
Yes. So at Hartford Healthcare, we have genetic counselors that are on site at our facility. They will counsel the patient. They test them appropriately for the test that is indicated. And also some of the referral comes from myself as a breast surgeon. For example, if I see a patient with breast cancer, there are specific guidelines that dictates who should be tested. As part of the coordinated approach, a genetic counselor is part of our multidisciplinary team. They also consult with these patients, and they're tested appropriately.
Right. And that's for women with a family history that may be at higher risk. What are the guidelines to get genetic testing and counseling?
A family history does play a crucial role, especially if there's a known family member, mom or dad, that has a known mutation that runs in the family. But also women with breast cancer at a much younger age are also candidates for genetic testing. A subgroup are women who are less than 60 with triple negative breast cancer, which conveys a more aggressive tumor biology. They are also candidates for genetic testing.
Yeah, and let's kind of break it down even a little bit further in terms of race. Now, African American women, we were talking about this earlier, we see higher rates in African American women. Why is that? Do we know at this point?
I don't think it's higher rates per se. We do see African Americans are more likely to die from their diagnosis of breast cancer. In fact, the statistics, to be exact, is about 42% more likely to die from their disease. It's multifactorial in terms of the cost. One has to do with access, it has to do with the time of diagnosis, late stage diagnosis, and tumor biology may also play a role. We do know that women of color tend to have a higher rate of the triple negative breast cancer, which is a type of breast cancer that conveys more increased risk of distant metastasis as well as recurrence.
We are talking with Dr. Camelia Lawrence. In case you're just joining us, she is a breast surgeon at the Hartford Healthcare Cancer Institute. We have some great questions here, and Samantha is asking, does having breast surgery reduction at a younger age put you at greater risk? Thanks, Samantha, for that question.
Samantha, no, there's no available data to suggest having breast surgery at a young age increases your risk for breast cancer.
Okay. Survivorship. There are survivor programs that we have. Let's talk about the other end of it. Somebody who's had breast cancer, they survive breast cancer, support groups. What do we offer for breast cancer survivors?
We have a host of different activities. We have a navigator. We have folks who are dedicated to the survivorship piece of the breast cancer treatment, and it's very important. In fact, we call it among ourselves not just survivorship, but also thriving during your survivorship. So it's really support group, counseling, therapy that's available, as meditation. It's really helping you to return to the activities of daily living, things that you used to do before you were diagnosed with breast cancer. Some of the group session deals with dealing with the side effects of chemotherapy, and also just emotional support from each other. Those who have gone through it, you kind of can bond and share your experiences. A lot of our survivors also serve as a guide. They provide support for newly diagnosed breast cancer. I'm always very moved and impressed when a newly diagnosed woman with breast cancer comes in and she's accompanied by a breast cancer survivor.
Yeah.
You know, it's very touching.
There's that unique bond there that can never be broken.
Absolutely.
So to speak. What should women know about breast cancer? You know, we know about self-breast examinations, mammographies, but what's kind of, this is your stage right now.
Yeah.
What is the one thing you really want to get across to women out there that is so important to you, whether you see it every day in your patients, whether it's what they're asking, but what kind of strikes you the most, and what's that message?
Early detection, in getting your mammography. Time and time again, I meet women who I wish I had met earlier because at the time of their diagnosis, the cancer is perhaps larger or may be already be present in their lymph nodes. The message, a take-home message, that breast cancer is really not a death sentence. We've come such a long way, but until we find a cure, the ultimate goal here is to find a cure for the disease, but until we get there, it's so important to have your screening mammogram done. And follow through on recommendation. If a short interval follow-up is recommended in 6 months, get it done. If you need to have a biopsy done, get it done so that you can get a definitive answer as to what that abnormality in your breast is. And
and compared to years ago to where we are now, we truly have come leaps and bounds where you would see women diagnosed with breast cancer and not survive. Women are surviving today.
Oh, they are. I mean, I have patients in my practice who've been diagnosed 20, 30, 40 years ago.
Wow. It's incredible.
Yeah.
Are there signs and symptoms that people don't necessarily know about when it comes to breast cancer? We talk about the lumps and we talk about things identified in mammographies. Is there anything that we should be aware of that maybe we don't know about?
Well, I always encourage my patient, any changes within the breast, such as a dimpling that you've noticed, skin color change, any nipple discharge or retraction or inversion that you notice, it's worthwhile to consult with your medical doctor as opposed to assuming that it's benign or it's nothing to worry about. And sometimes patients are fearful, but fear is not a strategy.
Right.
So it's important to get it assessed because the majority of time when women present with lumps in the breast or abdomen, it turns out to be benign. But there is a subset where it's not going to be, and if it's not in your case, you want it to be identified as early as possible because that's the window that offers you the best option for treatment and cure.
Sure. And when you do your self-breast examinations, you should actually look at your breast too to see if
Yes.
there's any physical changes, right?
Yeah.
In terms of the size, and does that play a role too?
Yes, the size does. You're looking for comparison. You're comparing both sides. You're looking for any dimpling or changes that weren't present before. I usually tell women you can examine while you're in the shower, but also examine in front of a mirror because that you'll
Right.
see, notice any changes that's there. The data available does not show that there's any evidence that women who do self-breast exam has an increased survival. But I personally think that a woman who examines her breast and knows her body, she knows the landscape, is going to be more equipped to pick up on any changes within the breast.
As soon as they happen.
Yes.
Right, and not delayed because you are familiar with your
Correct.
anatomy in that area.
Yes.
So I think is so vital. We talked about a little bit about breast density, but I want to take it one step further. Is what does it mean for a woman to have breast dense? What's the percentage? What do women out there need to know if they have dense breasts?
So when you get your mammogram, the radiologist is the person that interprets it and determine the level of density of your breast. And there are 4 main categories, which is usually not disclosed to the patient, but they're told if their breast is dense and whether an ultrasound is recommended or not. The breast is made up of fibrous tissue and fatty tissue. The fibrous tissue shows up as white. The fatty tissue shows up as black. Women with fatty replaced breasts is a really nice, easy mammogram to read if there was a cancer to present on the mammogram, but it's those with dense breasts that makes it more difficult. Also, in addition, the data shows that women with dense breasts has a slightly more increased risk of breast cancer. We don't exactly know why, but they do have an increased risk.
Yep. We don't hear about this often. We don't talk about it often, but men with breast cancer. And as you and I were talking earlier, there is a very small percentage, but a man with breast cancer who has a daughter could in fact pass that along to his daughter.
Yes, absolutely. So male breast cancer is much rarer than women with breast cancer. We see about 1 to 2% in the United States yearly, which accounts for about 2,000 men. And a majority of time, it's usually due to a genetic mutation. But men can get breast cancer, and if there is a mutation that is responsible for a male breast cancer, that can be transmitted to both their daughters as well as their sons.
So, a man who maybe had a father that had breast cancer, he would be a candidate for genetic testing, counseling?
Yes, he would be, yes. And any man diagnosed with a breast cancer is a candidate for genetic counseling and testing.
Okay. We have lots of other questions coming in below here that are quite popular. But in your practice, in terms of research and where do we go from here? We've come, like we said, we've come leaps and bounds. We've come so far. What's next? What can we expect?
From a surgical standpoint, I think we're going to see less surgery. I think as we learn more about breast cancer and how it manifests and how it behaves, I think we're going to see less surgery. We're already starting to do less axillary dissection with the advent or the information it was yielded from the Z11 trial. There's a subset of women who are having lumpectomy with sentinel lymph node biopsy that we know that do not need to go on to have complete axillary dissection even if they had 1 or 2 positive lymph nodes. There's some cancers that are actually ongoing clinical trial that is managing some DCIs conservatively without surgical intervention. So over time, as we learn more about breast cancer, I think we're going to see less surgical intervention.
We're already kind of starting to go down that path.
We
a
are.
little bit
Less
now
is
with
more in some cases.
We're right, with immunotherapy, and we're starting to see that already.
Yeah.
We have another question. Somebody says, I am 30, no history of breast cancer. When should I get checked?
The recommended age for you with no family history of breast cancer would be age 40. I would say consider getting your mammogram.
Betsy on Facebook asks, I know so many women who've been diagnosed in their 40s and 50s. Is the incident increasing, or are we actually finding it earlier? Thanks, Betsy.
That's a good question, Betsy. I think we're finding it much earlier. The technology has increased, especially now with 3D mammography. We're finding cancers when they're very, very small and much earlier. So we're definitely picking up earlier cancers.
Yeah, let's talk about the 3D mammography
Yeah.
versus regular standard
2D, yeah.
mammography. What's the difference?
Well, 3D mammography, what it does is it takes the breast and it cuts it into thin slices. So it gives the radiologist an opportunity to really scroll through the actual breast itself. Whereas a 2D, you're getting a two-dimensional compressed view. And what we've found with the 3D mammography is that our callback rates are significantly decreased, and we also finding cancers are much smaller, much earlier stage.
And who's a candidate for the 3D mammography?
Any woman is. I think the recommendation is geared primarily towards women who have dense breasts, but any woman can get a 3D mammography.
So women with dense breasts, if you get the mammography and ultrasound, would that replace the ultrasound, or is that in conjunction with the ultrasound?
It's in conjunction. So mammography is not replaced by ultrasound. And the reason behind that, there's certain findings that are present in mammography that will not show up on ultrasound. And a perfect example of this is microcalcification. Small groups and clusters of increased microcalcification usually tells the radiologist, based on their shape and size, that something is going on within that area that warrants a biopsy. They're so microscopic that on an ultrasound, you're not going to see these microcalcifications. So the ultrasound is used in addition to mammography, not to replace the mammogram.
Here's a great question from Becky. They found a cyst in my mammogram. Is that a precursor to cancer, or can they turn cancerous?
No, the majority of cysts are benign. Simple cysts are benign. We have an entity that's called complex cysts. A lot of times those are follow-up for reassessment, but having a simple cyst within the breast does not increase your risk for breast cancer.
Does that just mean you produce like calcifications of cysts, like and they couldn't turn cancerous? Or?
No, so a simple cyst is just a fluid-filled sac, essentially, in the breast, and it does not, they come and they go, especially in premenopausal women. They're not associated with breast cancer.
Okay, great. What does it mean to be in remission? If someone has gone a year without a recurrence, what does that mean?
What it means is that there's no evidence of disease at a time. And, you know, for breast cancer, we don't like to use the word cure because you don't know 100%, but no evidence of disease. There's no evidence of recurrence of the disease. So remission means that there's no evidence of the disease process at this time.
Right, so you would categorize that person as being in remission of their cancer. Is someone more, here's another question, is someone more at risk if she is overweight?
We know that obesity plays a huge role, not just in breast cancer, but in all cancers. And obesity does increases your risk.
Great. Of course, there's a number on your screen, but for more information or to schedule a mammogram or to get connected to a physician like Dr. Lawrence, you can call our Cancer Connect line at 1-855-255-6181. So many different aspects to breast cancer to talk about, and like I said, we've come so far in terms of the treatment. Are there any other lifestyle factors that play a significant role in possibly developing breast cancer?
In terms of lifestyle, I think diet and exercise. It's a conversation that I have with my patients, as well as tobacco use. Those are some of the basic things that we can do to help to reduce our risk of breast cancer.
And then I know we've talked in the past about lymphedema therapy for patients with breast cancer that some women go through, and that does help in terms of treatment as one modality.
Yeah, so lymphedema is a sequelae of women, usually for women who undergo axillary dissection, which is removal of all the lymph nodes at the time of their breast surgery. What it is essentially is a permanent swelling of that upper extremity. And lymphedema therapy helps to decrease the symptoms. In our practice, any patients who undergo an axillary dissection are usually have a consultation with our specialist to educate them as to what to look out for in terms of the beginning symptoms of lymphedema development, because early intervention is key in that setting as well.
Absolutely. We have a question, Heather, on Facebook. She's asking, when should a daughter of a survivor be tested? Teenage years, later in life?
I wouldn't recommend in teenage years because it's a lot of information to discuss. I will tell you that the testing is really looking for that genetic mutation, and the start time, if you do have the BRCA1 or 2 mutation, to start screening is age 25. So you do have some time, Heather, before testing.
you go on that road. And speaking of the BRCA1 gene, women who have that, and we've seen, years ago in the news, it was sort of a hot topic that if you have that gene, some women take some pretty advanced steps in terms of, removing the breast. Or what is your take on that if you have the BRCA1 gene?
The current guidelines for women with the BRCA gene is risk-reducing bilateral mastectomy. And I think we all sort of describe it as a Jolie effect. Angelina Jolie had both breasts removed. But keep in mind that the BRCA mutation not only increases your risk for breast cancer, it also increases your risk for ovarian cancer.
Right.
So there are risk-reducing strategies such as removal of both ovaries that's usually performed to reduce your risk. The whole idea is to remove the organ before the cancer develops.
Right. Is that, so that's not too aggressive of an approach?
No, that is a standard recommendation nationally for women who have the genetic mutation, BRCA mutation, is bilateral mastectomies.
So women who have that gene and their daughters, they would start at age 25.
25, you'd start your screening mammography. That's a recommended age. And if an ultrasound is indicated, which is not unlikely because the younger you are, the more dense your breast is likely to be.
Right.
So they'd probably get mammography and ultrasound.
And would let's say a 25-year-old is identified with the BRCA1 gene. What is the next step for her at that point?
Yeah, within the Hartford Healthcare Cancer Institute system, we have what's called a high-risk surveillance program. So these women are enrolled within our program, and they're monitored much more closely. A woman that's 25 with the BRCA mutation helps them to plan their life, so to speak. Knowledge translates into vigilance. So if they're planning having children or want to determine a time at which they will undergo the mastectomy, they may elect to start their family planning much earlier.
And women with breast cancer, let's say they're pregnant and they're diagnosed with breast cancer, how does that all play out?
It adds an additional layer of complexity when you're pregnant with breast cancer. Keep in mind that the clinical breast exam is limited in a pregnant woman because the breast becomes engorged when you're pregnant. But we do try to mirror the same treatment algorithm for the non-pregnant woman with the pregnant woman. The treatment is slightly different in terms of, it depends on where you are within your pregnancy, whether you're in the first trimester or the second trimester. For example, chemotherapy is only initiated during the second trimester. We cannot do it in the first trimester. Radiation is never given at all throughout the pregnancy. Anti-estrogen therapy is usually not started at all throughout the pregnancy.
And now some women out there who may have had breast cancer and have survived breast cancer, can they become pregnant?
Yes. In fact, in our premenopausal woman who desires childbearing, if you are diagnosed with breast cancer in the Hartford Healthcare System, there's usually consultation with our fertility clinic and to have the discussion regarding fertility post your treatment for your breast cancer and how to optimize that.
Right, so that is good news for women who have breast cancer, because a lot of times you hear of some women who have had breast cancer who it's not recommended they become pregnant.
Correct. In some cases that may be, but it's really individualized and it's based on what the other factors may be in terms of health risk.
What are some of the myths and the misconceptions that sort of kind of get under your skin out there that you really want women to know, hey, that's not true?
Mammography. I often meet patients out or individuals out in the public and, well, I heard it's extremely painful, so they have not had their mammogram. Well, it's uncomfortable, I would say, for some women, but it's not painful, and the benefits that can be gained from having your mammogram far outweigh the slight discomfort that you may have. And now with advances in technology, for example, at the Cancer Institute in Plainville, there is the mammography system is designed where the woman can control the amount of compression in order to get the mammogram image. So we've come a long way
yeah.
with that. It makes it more convenient. Other myths are men do not get breast cancer. We talked about that earlier. That's not true. We do have patients who say mammography will cause me to get breast cancer. The amount of radiation that you get from the mammography is very tiny. It's perhaps equivalent to you and I walking outside on a very sunny day. So those are some of the myths that I try to dive into and have discussion about to encourage women to get their mammogram.
Right, yeah, and some women just are looking for an excuse not to get it.
Yes,
and
any excuse not to get it.
Right, and it is not that bad.
Yeah.
I mean, it's always, it's seamless, really.
I'll be able to tell you better at the next month when I get mine.
Yes, you will. I can tell you it is not bad,
Yeah.
and it's so important to be vigilant and to get that every single year. And what, you know what else too is important? To kind of have that buddy system, you know, because it can be kind of scary to do it on your own.
Yeah.
But, you know, really, if you have a best friend, if you have somebody out there, schedule it together. Make it kind of a girl's day out.
Yeah, I will tell you, one of my girlfriends and I, Jill and Trevor, one of the program that we talked about is called Bosom Buddy.
Yeah.
Where it's a accountability partner.
Right.
You pick a day when you go in for your mammogram. It may be followed by a spa treatment after or a lunch date, but it's really encouraging each other, holding each other accountable to getting their screening mammogram done.
Yeah, it's kind of taking that fear out of it and making something fun out of it. We also have a question from Betsy. Can you have the BRCA gene and never know it? Do you know the percentage of people who carry it?
You can have the BRCA gene and not know about it. In fact, I would say the majority of people don't know they have the gene. I don't know off the top of my head the percentage of women that actually have it in the United States. But usually women who have the BRCA gene, there's some family history of first generation who may have it. And it's probably about 1 in 400 women who have the BRCA gene.
Yeah, and so if you don't have somebody in your family with the BRCA gene, but maybe you're the kind of the catalyst to start that.
Yes, yeah.
How do you know?
The recommendation would be to talk with your doctor, and your doctor will refer you to a high-risk program such as the one that we have with Hartford Healthcare, where you can be evaluated, you'll be referred to a genetic counselor and be appropriately tested.
Yep. And how does it usually work? Because this may be another myth too, like if your grandmother has it, you know, it sort of skips a generation and that means you're going to get it. Is that a myth or is
that's a myth. There's no guarantee that you're going to get it. So we get half of our genes from each parent. So half from mom, half from dad. And it can be transmitted on either side. So if dad may be carrier of the gene and never had breast cancer, and you being a daughter may have inherited that gene from him and do develop breast cancer.
Let's suppose here's another kind of scenario that may be familiar with people out there. Let's say you really don't have a family history of breast cancer, but then you have aunts and uncles that are older, maybe in their 70s or 80s, who are now being diagnosed with cancer. Does that automatically put you at an increased risk when you've had no family history, but now you're seeing older women in your family getting it? Does that mean you're at risk now? Are you placed in another category?
It slightly increases your risk, but I will tell you the majority of breast cancer that we do see in women, there's no family history. They are the first in their family to be diagnosed with breast cancer.
Yep. Great. Are you more prone to breast cancer if you have survived other cancers like, let's say, leukemia?
Not necessarily. The subgroup that we talked often about are those who've had lymphoma that has been treated with radiation, in particular mantle cell radiation, which is radiation to the sternum. We do see an increased risk of breast cancer in those women.
And women who have survived breast cancer, who've had a bout with breast cancer, are they at an increased risk of developing cancer again?
Yes. Once you've had one breast cancer, you're at an increased risk for developing subsequent breast cancer. Any woman that's diagnosed with breast cancer is usually followed very closely going forward, assessing for any early signs of recurrence of the initial cancer or a new cancer development.
You know, really the takeaway message here is when we talk about breast cancer, really all types of cancer, is to be vigilant, have your mammograms, get the appropriate screening, because early detection really, you could say it till you're blue in the face, but early detection does save lives.
It does, absolutely.
You see it every day.
I see it every single day. It does. It makes a huge impact and a huge difference. So get out there and get your mammogram done today.
Well said, and you will be getting it done next
Yes,
month.
I will be.
so
I'll tell you all about
we
it.
are very excited. So we'll have to have you back. It's always a pleasure to talk to you.
Right.
Thank you for your expertise and your knowledge in this area. I know it's helped so many women out there, so we thank you. Thank you.
Thanks for having me.
And so again, for more information, to schedule a mammogram or to get connected to a physician like Dr. Lawrence here, breast surgeon, call our Cancer Connect line at 1-855-255-6181. And as always, thank you for your great questions and for joining us. I'm Hartford Healthcare's Tina Verona. We'll see you next time.